Mr. James Wilson, 68-year-old male history, small cell lung cancer, new diagnosis, starting chemo tomorrow. Hypertension, COPD. Medications, lisinopril, tiotropium, PRN lorazepam. Presentation, brought to ED by daughter. Dad's confused and vomiting. He's been drinking water nonstop, but can't stay awake. Vitals, BP 110/68, HR 54, RR 10, shallow, temp 36.8 degrees Celsius, SpO2 92% RA physical. Neuro, Glasgow Coma Scale 8, E3V2 M3, disoriented, tremors. RESP, coarse crackles by lateral basis. Skin, cool, clammy, no edema. Labs stat, Na, 112 milliequivalent/L, severe hyponatremia. Serum osmolality, 240 mosm/kg. Urine osmolality, 520 mosm/kg. Urine Na, 42 milliequivalent/L. BUN, 6 mg per deciliter, CR, 0.7 mg per deciliter. Diagnosis, SIADH secondary to lung cancer. Most urgent initial action. A. Administer IV lorazepam. B. Obtain airway support equipment. C. Start 0.9% in ACL IV bolus. D. Check blood glucose. Answer B. RR10 plus GCS 8 equals risk of respiratory arrest. Secure airway first. Which finding confirms SIADH? A. High urine Na. B. Low serum Na. C. High urine osmolality plus low serum osmolality. D. Low BUN. Answer C. Urine osmolality, serum osmolality is diagnostic for SIADH. The provider orders 3% hypertonic saline. Nurse's priority action. A. Infuse via peripheral IV. B. Insert central line immediately. C. Give via IV push. D. Administer with furosemide. Answer B. Hypertonic saline, greater than 3%, causes phlebitis/extravasation. Central line required. During 3% NaCl infusion, the nurse monitors for A. Hypertension. B. Worsening confusion or seizures. C. Hypoglycemia. D. Bradycardia. Answer B. Rapid Na correction 8-10 milliequivalent/L/24H risks osmotic demyelination, seizures/coma. Which medication is contraindicated? A. Furosemide IV. B. D5W infusion. C. Lorazepam IV. D. Ondansetron. Answer B. D5W dilutes serum sodium, further worsens hyponatremia. The patient develops muscle twitching. Next action. A. Administer potassium chloride. B. Stop 3% sodium chloride and notify provider. C. Increase infusion rate. D. Check magnesium level. Answer B. Twitching suggests rapid Na correction. Hold hypertonic saline to prevent demyelination. Muscle twitching in a patient receiving 3% hypertonic saline, used for hyponatremia, may be an early neurologic sign of overly rapid sodium correction, which puts the patient at risk for osmotic demyelination syndrome, ODS, a dangerous and often irreversible complication. Goal for initial sodium correction. A. +1 milliequivalent per liter per hour. B. +4 to 6 milliequivalent/L in first 6 hours. C. +10 milliequivalent/L in 2 hour. D. Normalize within 1 hour. Answer B. Correct sodium by 4 to 6 milliequivalent/L in 6 hour for severe symptoms, then slow to 0.5 milliequivalent per liter per hour. Which nursing intervention reduces cerebral edema risk? A. Trendelenburg position. B. Elevate head of bed 30 degrees Celsius. Apply ice pack to head. D. Restrict O2. Answer B. Elevate head of bed reduces ICP by enhancing venous drainage. The provider orders fluid restriction. Nurse teaches A. Drink 3-liter water daily. B. Limit fluids to 800 milliliters per day. C. Avoid salty foods. D. Take diuretics with meals. Answer B. Fluid restriction 800-1000 milliliters per day is first-line treatment for SIADH. Which assessment requires stat intervention? A. Urine output 40 milliliters per hour. B. New onset focal seizures. C. BP 118/72D. SpO2 94%. Answer B. Seizures indicate severe cerebral edema or rapid sodium shifts. Sodium rises to 128 milliequivalent per liter in 8 hours. Next priority. A. Discontinue hypertonic saline. B. Switch to oral salt tablets. C. Administer desmopressin. D. Increase fluid restriction. Answer A. Sodium over 125 milliequivalent per liter plus symptom resolution equals stop hypertonic saline to avoid overcorrection. To prevent overcorrection, the nurse prepares A. IV insulin. B. IV D5WC. Oral fluids. D. K-exhalate. Answer B. Asterisk rationale. D5W relowers sodium if correction too rapid. Target less than or equal to 8 milliequivalent per liter per 24 hour. The provider adds demeclocycline. Nurse understands this. A. Treats lung cancer. B. Blocks ADH effects in kidneys. C. Reduces seizures. D. Increases thirst. Answer B. Demeclocycline induces nephrogenic DI, counteracts SIADH. Which dietary instruction is correct? A. Restrict protein. B. Avoid salt. C. Eat salty snacks liberally. D. Limit potassium-rich foods. Answer C. Rationale. High sodium intake helps increase serum sodium. Patient develops sodium 135 milliequivalent per liter, but GCS drops to 8. Suspect. A. Pulmonary edema. B. Osmotic demyelination. C. Brain metastasis. D. Sepsis. Answer B. Delayed neurodecline after rapid sodium correction equals central pontine myelinolysis. Most critical discharge teaching. A. Weigh yourself weekly. B. Report headaches or confusion immediately. C. Restart all home medications. D. Limit activity. Answer B. Neurosymptoms indicate relapse or complications. Which chemo drug likely triggered SIADH? A. Pembrolizumab. B. Cisplatin. C. Tamoxifen. D. Imatinib. Answer B. Platinum agents, cisplatin/carboplatin, are high risk for SIADH. Patient asks why fluids are restricted. Best response. A. To prevent kidney damage. B. Your body holds too much water, diluting blood sodium. C. It reduces vomiting. D. It helps breathing. Answer B. Simplified pathophysiology explanation promotes adherence. Which finding indicates treatment success? A. Urine output 20 milliliters per hour. B. Serum osmolality 200 mosm per kilogram. C. Sodium 135 milliequivalent per liter with clear mentation. D. Weight gain 2 kilogram. Answer C. Normal sodium plus resolved neurosymptoms equals effective management. Critical safety alerts. In SJDH, confusion isn't just tiredness, it's cerebral edema brewing. Nurses save brains by catching sodium drops before seizures start. Risk. Nursing action. Not correction greater than 10 milliequivalent /L/24H. Hold hypertonic saline, give D5W. Seizures. Benzodiazepines plus airway protection. Pulmonary edema. Diuretics. Furosemide plus O2. Chemo triggers. Hold cisplatin/vinca alkaloids. Mnemonic. Sodium for SIADH emergency. Seizure precautions. Osmolarity, urine over serum. D5W ready for overcorrection. ICU monitoring, neurostatus. Under 800 milliliters fluid restriction. Max sodium correction 0.5 milliequivalent per liter per hour after initial rescue.